Hi, everybody. Thanks for tuning in. This has been an awesome Eyes on Dry 2023. I'm so impressed with what I've heard this meeting. And I'm really glad you're here for this session because you may think you know all you need to know about cyclosporin, but au contraire, mon frere, we're going to present to you some special features of this particular formulation, some brand new data that hasn't been presented before, and you're going to walk away with a whole new appreciation for this particular tool in your dry eye toolkit.
Awesome. Looking forward to it, Laura. Great introduction. Thanks for joining today, and appreciate you doing this. Looking forward to it. Like you said, not your grandfather's cyclosporin, right? We've all used this for a long period of time. Different formulation, different concentration, but new data as well. So looking forward to presenting that today. So without further ado, we'll kind of jump right in and talk about this here. So Sequa, how is this different for you and your patient as far as a physician standpoint, as well as a doctor? So as doctors, we want therapeutics that work fast, right? There's been an unmet need and a gap in a lot of therapeutics we've had historically that took time to work. Another unmet need and challenge was tolerability, right? And we see that in the clinic from patients complaining about tolerability. We want something that works quickly, and we also want something that obviously can be tolerated by patients so they can stay on therapy a long time there. Running through here, obviously, disclosures, this is a Sun presentation, and on label here, looking at this, so CEQUA we know is at BID, once in the morning, once at night, about 12 hours apart. That is sort of the dosage there. But we know the indication, right? We look at our godfathers of inflammation starting back in 1999, Stern, Pflugfelder, some of the great research that came out there that really hammered home aqueous deficient dry being caused by inflammation there, right? So we know there's many reasons for dryness, multifactorial, it's complex, it's not that easy, but we know inflammation is pretty much present at all levels, even if it's not clinically seen or not. This is an immunosuppressant. We have 3 immunosuppressants in this category, which we actually will talk about today. But this is a calcineurin inhibitor, ultimately working to suppress inflammation, helping the body to produce more natural tears. To me, the competition is really artificial tears because of a lot of our colleagues are still using that, but it's nice to go forward and do something more than just a palliative treatment, ultimately prescribing, using something that can suppress inflammation, helping the body again to increase natural tears there. Important safety information. I'm going to kind of bump and run and go through this because we will touch on adverse events and different things. One thing we'll add here, if you're using contact lenses, make sure to do this drop beforehand, at least 15 minutes prior to installation there. I'll let you take it there, Laura, and dive into some of the dry eye disease overview.
Awesome. So I love that you highlighted this inflammation situation in dry eye. And that really is my primary target when I'm addressing the patient in front of me. We know inflammation is at the epicenter. We know it disrupts homeostasis, and those become treatment goals. How am I going to control the inflammatory load? How am I going to restore homeostasis? And these immunomodulators are critically important in achieving that, because what's happening, I'll get into that in just one second, is you've got this decreased tear production, hyperosmolarity, damage to the surface, perpetuating inflammation, chronic damage, self-perpetuation, neurosensory compromise. Doctors Hardin and Chang did an awesome job on their neurotrophic keratitis lecture. I'm like, yes. So fabulous job on that. We have 3 main immunomodulators. We've got Restasis, Xiidra, and now we have CEQUA. And we're going to talk about what makes CEQUA unique and special. Next slide. Okay, so this is an old data, $3.84 billion in annual cost. That's very, very old data. And that's just what the insurance companies are complaining about. The actual socioeconomic impact for the patient is over 50 billion, that's with a B, in the US. And even that's old data. So it behooves us to jump on this, because really what you're helping address is that patient's impact on their quality of life, their activities of daily living, things that they want to do, things that they require, things that they have to do, spreadsheets at 4 o'clock in the afternoon. You want to help maintain your patient's vision long-term, and inflammation control is paramount to that. Next slide. So how does this thing get started? It's an innate immunity that's become adaptive immunity, and it's chronic and self-perpetuating. Mother Nature forgot to code for stops on the system, and dry eye disease jumps the fence and becomes chronic and self-perpetuating. And that's where we need immunomodulatory therapy. That's like calling the cops on a mob situation, right? So you need to get in there and control this chronic self-perpetuating inflammation in order to address the neurosensory compromise, the inflammation, the impact on tear production, and drug delivery has everything to do with restoring this elegant system that Mother Nature created. Homeostasis is where it's at. Let's get there. How do we do it?
Great point. No, I love that here. So great touch on inflammation, but let's zoom out for a second and really talk about, sort of the demographics here, right? So we know dry, the number one risk factor is age. As we increase in age, we see a decrease in lacrimal function in men and women. And one key important thing is that doesn't change up until age 38. So there's no difference in gender. So age being the highest number one risk factor for dry. Number two is typically gender. So we see this higher in women, but not under the age of 38. There's really no difference significant between male and female. So historically, we thought of dry as like, a 75-year-old female with Sjogren's that was really in the chair complaining about dryness, using tears all day long. Because of research like DEWS 1 and DEWS 2, and then just much more prevalence of doing a better job looking for this, we know that demographic is changing there, right? So we look at the prevalence. About 30 million Americans in the United States have dry disease. I think that's a conservative number. Unfortunately, only about 16 million, roughly a little bit of a half of those patients have ever been diagnosed. And then even maybe about 1 million have actually ever been given a prescription there. So another unmet need. We'll talk about several of those today. One was being efficacy and tolerability. Now another one is just actually getting a prescription there, right? So a lot of people walking around without a therapeutic. We see this very common. We see this more frequently now, right? Is it changing? Not really. I think we're doing a better job looking for it. So the face of dry may be getting a little bit younger, maybe more male and female, not just the elderly females we thought of historically. And that belief is really due to digital device use and those sort of things here. So if you're looking at a patient, try not to judge based on necessarily age and gender, and look for this in younger patients, even look for this in males. So we look at this, and there was an unmet need as far as therapeutics historically that we worry about compliance, right? Glaucoma is a sight-threatening disease that can cause blindness, but there's no symptoms. So to me, dry is more rewarding because we can help patients feel better, ultimately decreasing some of those symptoms that Laura just mentioned there: burning, stinging, irritation, those things. Well, we look at the data. There's been a low adherence rate there in the past few decades. And why is that? Well, we look at retrospective studies, one by Francis Maw, that looked at patients who discontinued cyclosporin. That paper was done in 2012. One of the main side effects that caused patients to stop therapy was burning and stinging. A more recent paper by Daryl White looked at really, why do patients decrease treatment or stop treatment and have poor continuation rates? Ultimately, that was because they weren't getting, symptomatic improvement, not feeling better there. So discontinuation of eye treatments may lead to disease progression because patients really aren't on therapy. We as doctors want our patients to be compliant, to be on therapy, to get better, to start feeling better. We know there's no cure, but we can put them on a journey working towards that, getting better there. Ultimately here, several different points here. This was a cool paper by Asbel that really looked at how can we develop a therapeutic in dry eye. A paper looked at, more of an empathetic approach to patients. What do patients want when they have a new dry treatment? And so this looked at an algorithm to really develop a new treatment, potentially not necessarily relevant to any therapeutics we have today, but how could we be empathetic and talk to patients about what they would enjoy when they get a dry drop? Ultimately, patients selected that they want something that works really quickly, relieving symptoms fast, ultimately decreasing inflammation and have a fast onset of action. And then again, something that's tolerable. If something has, a lot of burning, stinging, dysgeusia, these different things, a lot of patients will discontinue therapy if they think it's causing issues with them, side effects, or just unable to stay on therapy there. We'll look at this and talk about how it relates to two therapeutics that are out there previously prior to CEQUA being out there, right? Cyclosporin, as Laura mentioned, has been out for over 20 years now. We know a lot about this molecule, a large market share, 0.05%. Now we have a different version with CEQUA, 0.09%. But let's talk about Xydrol lifitegrast first. Okay, ultimately, the clinical trial efficacy. When we look at this, we think of Xydrol as being a quicker medication. The marketing that came out was great and was, maybe a lot of our colleagues felt like this works quicker because it was a different molecule, a lot stronger, different concentration. Ultimately, it failed to show significant effect at 2 weeks in 2 of the 4 studies, okay? ultimately, all 4 out of 4 trials did work at day 42 with that endpoint, but at 2 weeks, it failed in 2 of 4 studies there, looking at symptoms specifically. We look at clinical signs in those trials, significant effect at day 84 in 3 out of 4 studies, but there was no significant effect seen in Opus 2. Okay, ultimately, it did fail that endpoint there. So that we look at efficacy, sort of a belief that Xiidra works quicker, but we dig into the data, maybe not as quick as we thought in some of these trials. Restasis, FDA approved to increase natural tear production. That trial looked at Schirmer scores in 6 months. We see a significant increase in 6 months there. And then we'll look at adverse events. We know with Xiidra, the most common ones there, site irritation upon installation, dysgeusia, reduced visual acuity. It's not something a lot of our patients enjoy when they get visual blur from using these medications. And then ocular burning was 17% with Restasis there. Other adverse events on the right here, but this just highlights, again, talking to patients, talking to doctors, we want therapeutics that work quickly, and we want therapeutics that ultimately patients can tolerate and have good tolerability issues with there. So now let's talk about CEQUA. I will hand this off to Laura and let you dive into it. I see you chomping at the bit there.
This is so much fun. I love pharmacology. It's super interesting, and you should love it too, because the formulation matters, you guys. When we put a medicine in a delivery system, it depends on how you wrap the molecule itself, but it also depends on who else is in the neighborhood. And that's another reason why generics just are not the same. There's buffers, there's excipients that help address the ocular surface. There's electrolytes that help prevent cell death, particularly divalent cations. So there's all these other yummies in the mix of your medication delivery that contribute to the effect. That's why we run vehicle-controlled studies. It's easy to look good standing next to saline. But if you're standing next to the vehicle minus the drug and then measure the impact of the exact same thing plus the medication, now you've got data you can talk about. Next slide. And so that's what makes this special. So cyclosporin is this awesome natural molecule. We've been studying it since the 50s. It's a cyclophilin antagonist, decreases IL-2, IL-6, all that nerdy, awesome stuff. But it does not like water. It's like Jack Sprat's wife. It really wants fat. And so if you're going to get it through an aqueous tear layer to the ocular surface to deliver it, you got to wrap it in a nanomicelle, which is fat in the middle, water on the tails. And that allows it to become a solution. That's a unique way of delivering cyclosporin, a water-hating molecule in a water delivery system. You wrap it in a little fat bubble, little nanomicelle, and that allows it to get through the tears and delivered to the ocular surface where you need it. This is where the inflammation is happening. Next slide. And so here's why it matters. So when you look at emulsion formula cyclosporin versus nanomicellar, I'm talking about Restasis and CEQUA, in rabbits at the exact same concentrations, 0.05, CEQUA in this nanomicellar delivery system is 3-fold higher concentration in the cornea in this rabbit model. Now that's important. Some patients just need more inflammation control. Put this amazing immunomodulatory molecule that we have all this experience about, we understand how it works, to the scene of the crime where all that inflammation is happening. You've got to get the drug to where the mischief is happening. Next slide.
Before I jump ahead, I think you make a great point there. I think when this was launched, there was a lot of data or talk about in-cell technology, but this really highlights what it does, right?
Mm-hmm.
I mean,
and
we
why
know
it's important.
Yeah, we know cyclosporin. We liked it. It's efficacious. It's tolerable. But what if we change the platform, that in-cell technology, to allow this to penetrate better, increase bioavailability? Mm-hmm. Ultimately, we think, will that increase speed of a mechanism of action, which we'll talk about next year. We'll see.
Let's see. Let's see, this is number, okay. So because of that smart drug delivery and cell technology system, because of that 3x higher concentration, and that's just at the same 0.05, this is 0.09 that we came to market with. So you can imagine that it might be higher. I think that's maybe the secret sauce as to why we're seeing some of this incredible data that we're sharing for the first time with you coming up. Fast and efficient, let's get into it.
Yes, awesome. No, we'll do that for sure. So we'll look at that shortly. But again, going back to tolerability there, right? So It's nice to have three options, right? Not every patient does well on one certain medication. Not every payer will pay that certain medication. So it's nice to have three options on the market on these immunomodulators. But if we could pick a therapeutic, ultimately we want something that works quickly, as we talked about, and then is tolerable. When you look at the data here in the clinical trials when CEQUA was approved, very interesting when you look at this. So installation site pain was the most common adverse event, sort of side effect there, right? This leads patients to maybe discontinue drops if it's not tolerable and it bothers them. But when you look at this medication, 95% of these patients reported either no pain or that pain to be mild there. Again, I'll re-highlight that again. It's a big thing. 95% no pain at all, or if that pain was there, it was mild when they put this drop in their eye. We know most therapeutics in this category have side effects, but if they're not tolerable, they're not going to stay on therapy to get a breakthrough in symptoms, ultimately where they feel better and start getting better on that journey of getting better there. So it's pretty compelling when we look at this. One thing I like to really highlight when we go through this deck here. We look at the clinical trial safety. Again, most ocular adverse events were reported were mild or very existent or not. 95% had no pain or mild at all. The most common adverse event, again, we talked about installation site pain, 22%. The second most common, 6% had hyperemia in the conjunctival tissue. One big thing here in bold here, fewer than 3 patients in 100 actually stopped and discontinued CEQUA because of that installation site pain, right? So it's pretty well tolerated when you look at that 3 in 100 there. So if you think about this in the clinic, Laura, if you prescribe this next week, seeing 100 patients in that one day, I know you're busy on Monday seeing 100 patients, only about 3 would discontinue, right? We know not everyone would get this. There's other reasons for maybe not going to the pharmacy or whatever it is, but a pure level of discontinuation rate, 3% there is pretty compelling. Ultimately, we compare that to the vehicle, which we'll touch on here, is very tolerable and efficacious on its own, but the discontinuation rate in adverse events was 3.2% for CEQUA versus 1.1 with the vehicle. So we know some patients, no matter what we give them, they'll complain. That 1.1% represents some of that. There's not much delta here between active ingredient with CEQUA, what we prescribe patients, to what just the inactive ingredient there with the vehicle there. And the big thing here, we don't want to prescribe something that can cause visual blur, right? And patients can complain to that with certain therapeutics that are out there, but we see that in less than 1% in the clinical trials here. What do we not see with CEQUA? I think it's an important highlight here, important thing. There's no taste alterations, right? There's no dysgeusia. Again, it's nice to have 3 options out there, but therapeutics, some patients just don't tolerate dysgeusia and don't like that side effect. So CEQUA does not have that. And there's no other medication I know of in this class with no contraindications, right? So CEQUA has no contraindications at all on label there. So it's something that's very well tolerated, something that can help patients there. This is new data, something that's exciting, right? Looking at phase 2B and 3, new data that was cut from the old clinical trials, if you will, but they realized this maybe works quicker than they thought, okay? And this was some of the most exciting data I've seen about CEQUA in general. We've used it for several years now. It's nice to have in clinic. But when you look at this, anecdotally in the clinic, we always thought it worked quickly. We saw it worked quickly. Patients reported that it worked quickly. But now that was actually seen, looking at the data in a new way, improved total corneal staining after just 14 days.
Amazing.
Pretty compelling. Thoughts on that,
That's
Laura?
amazing. Oh, yeah, totally. Like, extrapolate that to everyday clinic, right? Like, when would improvements in corneal staining matter in a clinical situation, like pre-op LASIK, pre-op cataract? Like, those things matter because those pits, that staining, is going to impact your biometric readings and potentially your refractive outcomes. So this is very compelling and very exciting data, ad hoc analysis from the original phase 3 data.
Yeah, when I started using CEQUA, it was less induction therapy coupled with steroids. It was less of everything, right? We can now prescribe therapeutics that work quickly. Preoperatively is a great pearl. We can speed things up. No surgeon wants to pump the brakes and wait 2 or 3 months for a therapeutic to kick in. Patients are ready. They're eager. Younger patients with LASIK, contact lens patients, we need something that can work quickly. And ultimately, it's nicer to then prescribing 2 or 3 medications and high copays and all this stuff if we can just do it with one therapeutic there.
Yep. Avoid polypharmacy if you can.
Yep. We see with therapeutics 2 weeks, right? Maybe something quicker than we thought, improved symptomatic, as we mentioned there. What about statistically significant reduction in total corneal? We see it was working within 2 weeks, not significant, but there was improvement, but we actually still see significant improvement at 1 month there, okay? So statistically significant reduction in total corneal staining at 1 month. The key take home of this slide, the longer we use this medication, the better it works. That's how I counsel patients. You'll start feeling better maybe in 2 weeks. You may start seeing better in 2 weeks. All the different things we see here, this gets a reduction in total corneal staining. We look at the data in as fast as 28 days. The longer we use it, the better it works. One important thing here, which is new for CEQUA, is to talk about symptoms there. In the clinical trials, patients reported a meaningful reduction in symptom severity in as fast as 28 days, okay? So we see decreased staining in 2 weeks, total corneal staining being significant in 4 weeks, and now we have symptomatic improvement in as fast as a month there, really highlighting how well that in-cell technology, again, increasing bioavailability, penetration, all the things Laura mentioned, helping our patients get better quicker there. Patients reported a meaningful reduction in symptom severity. All right, so symptoms are good. Let's talk about that and dive into this a little bit. Laura mentioned saline, maybe not the standard of care. What do we do? Well, we talk about saline maybe making a bigger difference in delta with active ingredients versus placebo, but it's nice to kind of have two things in one. So we look at this, and there's not a big difference here between the inactive ingredients in the vehicle versus CEQUA when we talk about symptomatic improvement. Ultimately, that just sheds light on how well this sort of formulation of the vehicle actually does work. Anything you want to add there? I mean, we can look at the 30% decrease over time, but you want to speak, Laura, to the vehicle itself and kind of the secret sauce there and how that can work for patients?
Well, I think we already covered it. It's the composite and the medicine that work together, and that's why you set up studies this way of the vehicle and the vehicle plus the active. That's why we set up the studies the way we do.
Great point.
Okay, so improvement in visual acuity at 2 months. This is important. Again, this is ad hoc analysis of the original FDA data, and patients reported statistically significant improvement in vision at 2 months. That's a big deal. That has serious clinical implications for your contact lens wearers, for your LASIK patients, for your cataract patients. Like, we all care about vision. We're in the business of vision. And so this slide showing statistically significant improvement in visual acuity at 2 months, to me, is very compelling. And that's in addition with the reduced staining that we're seeing. And we're going to come up on that next.
Yeah, you mentioned as we were starting, there's no other drop I know of that we could prescribe to actually help vision on label.
Yes, amazing. So significant corneal clearing at 3 months. This is a big deal. So a third of the patients at study entry randomized to vehicle alone versus CEQUA, and 63% or twice that number had completely clear corneas at 3 months. Now, I've been practicing dry eye disease treatment for a very, very long time, and it's hard to get that much clearing in that short of a period of time. This is very compelling to me. It does have implications for visual performance and the overall health of the ocular surface. Does this, how do you feel about this particular juicy piece of data?
Yeah, looking historically, we know inferior corneal staining may be more about lag ophthalmos or exposure, keratitis, these things, and maybe not that clinically significant. Central corneal staining, we know that's a real dry eye patient. Those are more advanced, ITF guidelines, maybe level 3, more advanced with DEWs. So if you can clear 65% of the central cornea in that more advanced patient in 3 months, you got a therapeutic in the data that really shows it really does wonders there. Ultimately, that will help vision, which we see correlated to some of the stuff you mentioned earlier.
Yeah. And then, of course, tear production increases, right? So significant improvement in tear production. We want to see that. As we get the inflammatory load under control, as the ocular surface starts to heal, tear production starts to recover. We're starting to recover homeostasis. We're starting to restore that entire lacrimal functional unit. And so, of course, we see improvements in tear production at 3 months with patients that had over a 10 millimeter increase, and patients overall had about double their tear production compared to study entry. That's impressive. So you can take a very severe dry eye patient and double their tear production. That's big deal. That's clinically meaningful. And then if you're already just sort of mild, you can get them over the top and stabilize that tear film even further. So I see this having applicability in mild, moderate, and severe ocular surface disease.
Yes, so important. Natural tear film has over 2,000 proteins, lactoferrin, lysozyme,
Yes.
electrolytes. Mother Nature gave us those things because we need them. Synthetic tears just can't give us those 2,000 molecules and proteins. So this just really shows how well that can increase natural tear production there.
Mother's milk, not formula, right?
There you go. I love how you use that analogy. All right, so looking at this, so we want a therapeutic that works quickly. This story or the slide deck tells that story. We want to talk about tolerability, right? So real world treatment patterns in patients receiving CEQUA, Restasis, or Xiidra. We've never really seen a big comparison with this in a slide deck. So we'll look at this here. This actually looks at the Symphony Health Integrated Dataverse, which is a large amount of data from a national provider-based claims database. They can look. Ultimately, this was done in May of 2020 through 2021 of June, looking at patients that went on therapy with one of these three prescriptions. This paper was presented last year by Paul Kopecki at a symposium, ultimately looking at data. What is given in the real world through Medicare, commercial payers, Medicaid. Ultimately, we can look at that data and stratify the data and see ultimately how long patients are staying on therapy there. We see from a baseline period all the way to follow-up there, 3 months. Sorry, I'll go backwards here. Looking at this 3 months before index date when they were prescribed therapy, all the way out, again, about 12 months, a little bit longer there. What we see here ultimately is that looking at the data, patients stay on therapy with CEQUA longer, okay? What does that mean in the real world? If they can stay on therapy, they're going to get better. They're not going to discontinue it. It's not going to be this chronic cycle of the chronic progressive disease state. If we can intervene therapy, keep them on therapy, something that works quickly, it's tolerable, they'll stay on this. Ultimately, they'll have a better job of doing that. So patients, ultimately, we look at this, the mean average of treatment was 11.6 with CEQUA. Xiidra was 8.8 months, and then Restasis 7.9. Some of the interesting data here, but one published by Daryl White, the discontinuation rate, the mean average was 1 month for lifitegrast and 3 months for cyclosporin, 0.5% there. Ultimately, we see this in a different cut of data here from a different study, but ultimately sheds light on if patients can stay on therapy, it just helps them progress where they don't have to go on this chronic progressive cycle there. So after nearly a year, 360 days, more patients were still using CEQUA than compared to Xiidra or Restasis there with this large analysis of data there. Ultimately, here in a summary from day one, we see this. There's no or mild installation site pain. So 95% of these patients reported installation site pain to be mild or no pain at all. So if they can tolerate it, they will keep on it in theory. After just 14 days now, new data, we see that there's an improvement in corneal staining here, right? This works quickly. You can tell your colleagues, you can tell your patients, they will get better quickly. We see that in the slit lamp there. We see a reduction, significant staining reduction of total corneal staining in as fast as 1 month or 28 days. Laura highlighted the data here, improved visual acuity. No other drop has really been out there on label to show that. We see an improvement in visual. It's what we do as optometrists and ophthalmologists, helping patients see better. And then the reduction of these different points that Laura mentioned, 65% of central corneals being decreased in staining. And then after a year, more patients staying on CEQUA when compared to Xiidra and Restasis in that Symphony data there. We want medications that work quickly, ultimately helping patients feel better, and we want them to stay on medication there.
Focus on your patient's health and strive.
I'll jump through this here. Ultimately, CEQUA has saving options for all insured patients. Only Sun Pharma offers prior authorization support services and CEQUA Direct through Cover My Meds and Script Hero. Commercial, Medicare, government insurance, all these different things. There's a lot out there ultimately to help our patients, whether a PA is approved or it's denied. There are opportunities to get medication at lower cost, which is a good support program for Sun. We support that. Laura, before we conclude here, we got about a minute. Anything you want to add about the data today or any experience you have in the clinic using CEQUA?
Yes, I just want to say a couple things. One, I want everyone to disabuse themselves of the notion that immunomodulators take too long to work. It's just not true. So use these things early, use them often. It's fast, it's efficient, it works. I want people to really focus on controlling inflammation with each of their dry disease patients. And this is a great way to do it.
Yes, I agree. We know this is a chronic disease state. We know it's a progressive disease state. We mentioned some of the things, CEQUA, Restasis, Zyder today. Again, most of our colleagues are still prescribing artificial tears. Ultimately, that's just not going to treat the disease state, which you highlighted being inflammation. But if you're going to prescribe something, we need something that is efficacious, tolerable, works quickly, and our patients can stay on it there. So it's been great presenting with you, Laura. So much fun. I hope you have a great weekend. Thank you, Eyes on Dry, for having this today. Thank you so much.